Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Welcome back, future nurses, to another focused and high-yield session. Every day, we cover 2 to 3 major NCLEX topics that help you connect pathophysiology to real-world nursing practice. And today's topic is truly vital for understanding circulation and life itself. Our main focus today is arterial disorders, conditions where the blood supply to tissues is compromised, leading to pain, ischemia, and tissue damage. We'll explore critical conditions such as peripheral arterial disease, Buerger's disease, and Raynaud's phenomenon, breaking down their causes, hallmark symptoms, diagnostic clues, and nursing management strategies. In this lesson, we'll discuss how arterial insufficiency differs from venous disorders, why pain worsens with activity but eases at rest, and which nursing interventions can improve perfusion and prevent complications like ulcers or gangrene. You'll also learn how to interpret ankle brachial index values, identify classic skin changes, and understand the rationale behind key lifestyle modifications and pharmacologic treatments. By the end of this session, you'll be able to confidently differentiate arterial disorders from venous conditions and apply the right nursing actions during emergencies like acute limb ischemia. Hold on a second before we dive into the next NCLEX topic. I need to share something urgent with you. If you are serious about passing the NCLEX on your very next attempt, you cannot afford to miss the ultimate NCLEX crash course. More than 100,000 students have already cleared their exam with it, and you can too. Why is this course different? Because it gives you everything in one place. Live interactive classes, recorded lectures you can rewatch anytime, 5,000 practice-style questions, 30 practice tests, ebooks and PDF revision notes, a student planner, and detailed NGN question explanations. This is your shortcut to success. Don't wait, scan the QR code or click the link in the description now. You will instantly unlock free study content including NCLEX quizzes, PDF notes, and practice tests, plus access to our Telegram and WhatsApp groups with even more support. Shifting our attention to a real-life clinical scenario, imagine a 75-year-old client residing in a long-term care facility with a documented history of peripheral arteriosclerosis. During a thorough nursing assessment, the goal is to evaluate for signs of arterial insufficiency that may result from this chronic condition. The question asks which findings the nurse should expect to observe. The options include A. Thick, tough toenails, B. Flushed, ruddy skin, C. Hyperactive knee-jerk reflexes, D. Bounding peripheral pulses, E. Thin, shiny skin, and F. Decreased leg hair. The correct responses are A, E, and F. Thick, tough toenails, thin, shiny skin, and decreased leg hair. Delving deeper into the rationale, peripheral arteriosclerosis is a progressive disorder involving the thickening and hardening of arterial walls that results in narrowed vessels and impaired oxygen delivery to tissues. Over time, the skin and peripheral structures experience degenerative or trophic changes due to reduced nutrient and oxygen supply. Recognizing these characteristic findings during assessment is essential for early identification of arterial insufficiency. Now exploring option A, thick, tough toenails. This is a correct finding. When arterial blood flow decreases, the nail matrix receives less oxygen and nutrients, leading to slow growth and keratin buildup. The result is thick, brittle, and yellowish toenails, often described as trophic nails, which reflect chronic ischemia in distal tissues. Turning to option B, flushed, ruddy skin. This is incorrect because flushed or warm skin generally indicates venous congestion, inflammation, or even hypertension. In contrast, Arterial insufficiency produces pallor, coolness, and cyanosis, especially when the affected limb is elevated, due to insufficient perfusion. Considering option C, hyperactive knee-jerk reflexes, this too is incorrect since reflex abnormalities are neurological rather than vascular in nature. Arterial insufficiency affects blood supply, not reflex arcs, so exaggerated reflexes would suggest upper motor neuron lesions, not peripheral vascular compromise. Looking at option D, bounding peripheral pulses, this is incorrect because arterial insufficiency results in weak, thready, or even absent pulses distal to the obstruction. Bounding pulses are typically found in hyperdynamic circulatory states, such as hyperthyroidism or aortic regurgitation, not in ischemic limbs. Moving on to option E, thin, shiny skin. This is correct. Chronic hypoperfusion causes loss of subcutaneous tissue and atrophy of the skin layers, producing a smooth, glossy, and fragile appearance. The skin feels cool and may ulcerate easily because of reduced wound healing capacity. Finally, option F, decreased leg hair. This is another correct finding. Hair follicles are extremely sensitive to oxygen deprivation. Sparse or absent hair on the legs, toes, or dorsum of the feet signals prolonged ischemia and serves as an early clinical clue to arterial disease. From a broader pathophysiological standpoint, peripheral arteriosclerosis leads to narrowing of the arterial lumen through a combination of plaque buildup, fibrosis, and calcium deposition. This results in a drop in the ankle brachial index, ABI, below 0.9, confirming decreased arterial flow. Clients frequently experience intermittent claudication, characterized by calf or thigh pain that appears with exertion and subsides with rest. On physical examination, nurses typically find pallor on elevation, dependent rubor, cool extremities, and delayed capillary refill, all hallmark features of arterial insufficiency. These contrast with venous disorders, where the skin tends to be warm, swollen, and hyperpigmented due to blood pooling. Transitioning to the Stan-Coast clinical pearl. In arterial disease, everything below the blockage starves. The skin thins, hair disappears, nails harden, and pain worsens with activity, but eases with rest. Remember, pain on exertion, pallor on elevation, and pulse loss equals peripheral arterial disease, PAD. Next, reflecting on the Stan-Coast high-yield NCLEX pearl. To differentiate arterial from venous insufficiency, think in terms of color and comfort. Arterial equals pale, painful, pulseless. Venous equals swollen, warm, and relieved by elevation. Arterial ulcers typically form on the toes and lateral ankle, while venous ulcers appear on the medial malleolus. Moving forward into this scenario, a nurse is assessing a client diagnosed with peripheral arteriosclerosis who reports leg discomfort during physical activity. The key question here is, which clinical manifestation should the nurse most likely expect to observe during exercise? The available options include A, cyanosis of the feet, B, burning sensation in the toes, C, pain in both legs, and D, edema formation in the ankles. The correct answer is C, pain in both legs. To understand this clearly, peripheral arteriosclerosis is a chronic, progressive condition in which the arterial walls become thickened, hardened, and less elastic, leading to narrowed vessel lumens and reduced oxygen delivery to the distal tissues. During exercise, when the client's leg muscles demand more oxygen, the narrowed arteries fail to supply adequate oxygenated blood. This mismatch results in ischemia, causing the muscles to produce lactic acid and metabolites that trigger cramping, aching, or pain, a hallmark symptom known as intermittent claudication. This pain typically occurs bilaterally in the lower extremities, often in the calves, thighs, or buttocks depending on the site of obstruction, and it subsides with rest once oxygen demand normalizes. On the other hand, cyanosis of the feet, option A, indicates either severe arterial blockage or venous congestion that occurs at rest, not specifically during exertion. A burning sensation in the toes, option B, is more characteristic of neuropathic conditions such as diabetic neuropathy rather than arterial insufficiency. Lastly, edema formation in the ankles, option D, generally suggests venous insufficiency or right-sided heart failure, where fluid accumulates due to poor venous return, not diminished arterial perfusion. Consequently, the classic manifestation during physical activity in a client with arteriosclerosis is pain in both legs, relieved by rest, confirming intermittent claudication. a direct reflection of compromised arterial blood flow. Transitioning into a deeper insight with the Stand-Coast clinical insight. Arterial pain appears with activity and disappears with rest. Think of it as muscles crying out for oxygen. Intermittent claudication is the textbook signal that arteries are narrowing and tissues are starving for blood supply. Moving next to the Stand-Coast high-yield NCLEX-style. In arterial disease, pain equals activity, pallor equals elevation, and pulse equals weak or absent. In venous disease, pain equals standing, relief equals elevation, and edema equals common. Always distinguish arterial ischemia from venous congestion by analyzing the trigger, relief pattern, and location of symptoms. Moving into another critical clinical scenario, imagine a nurse caring for a client diagnosed with peripheral arterial disease who reports persistent coldness in both feet. The nurse must determine which intervention will effectively promote comfort and circulation while preventing complications. The available options are A. Apply a commercial heat packet directly over the feet. B. Use an electric heating pad for localized warmth. C. Wrap the feet in a warm, lightweight blanket. And D. Elevate the feet on a stool above the level of the heart. The correct answer is C. Wrap the feet in a warm, lightweight blanket. Clients with peripheral arterial disease have impaired arterial blood flow to their lower extremities due to atherosclerotic narrowing. This leads to reduced oxygenation of distal tissues, causing symptoms such as coldness, pallor, and intermittent claudication. The most appropriate nursing action in this situation is to apply gentle, indirect warmth, such as wrapping the feet in a warm, lightweight blanket or using soft cotton or wool socks. This technique conserves natural body heat, enhances local circulation, and avoids direct exposure to heat, which could damage ischemic tissue. Direct heat sources, such as commercial heat packets or electric heating pads, are unsafe for these clients because impaired sensation caused by ischemia or neuropathy prevents them from feeling excessive heat. As a result, burns or tissue necrosis can occur before the client perceives danger. Likewise, elevating the feet above the level of the heart reduces arterial perfusion due to gravity, which worsens ischemia and discomfort. In contrast, keeping the legs in a dependent position enhances oxygen delivery and perfusion to the extremities. Let us review the rationale for each option. Option A, applying a commercial heat packet. This is incorrect because clients with poor circulation and reduced sensation are at a high risk of burns and tissue necrosis from direct heat exposure. Option B, using an electric heating pad. Also incorrect, as it provides uneven localized heat and can cause deep burns in areas of ischemic tissue, making it unsafe for clients with arterial insufficiency. Option C, wrapping the feet in a warm blanket. This is correct because it delivers gradual warmth safely, conserves body heat, and promotes circulation without harming fragile tissue. Option D, elevating the feet on a stool. This is incorrect since elevation decreases arterial blood flow and oxygen delivery, worsening ischemic pain and coldness. To deepen understanding, let us highlight a Stand-Coast clinical insight. In arterial disease, keep the feet warm, not hot, and down, not up. Dependent positioning improves blood flow, while direct heat risks burns due to poor sensation. Finally, reinforcing with a Stand-Coast high-yield NCLEX-style. Arterial equals hang down for warmth, venous equals elevate for relief. Always avoid heating pads in clients with impaired circulation. Protect ischemic tissues from both cold and excessive heat. Moving forward into an important vascular assessment concept, imagine a nurse using a Doppler ultrasound device to evaluate peripheral arterial circulation in a client with suspected peripheral arterial disease. The question is, which nursing technique should be implemented to ensure accurate detection of blood flow? The available options are Option A, place the probe beside the ankle. Option B, apply acoustic gel to the skin. Option C, record the time of capillary refill. And Option D, measure the temperature of the skin. The correct answer is Option B, apply acoustic gel to the skin. When assessing peripheral circulation with a Doppler ultrasound, applying acoustic gel to the skin directly over the artery is the correct and essential technique. The reason is that air is a poor conductor of sound waves, and if the probe is placed on dry skin, the ultrasound beam will not transmit efficiently through the air gap. The acoustic gel serves as a bridge that allows the ultrasonic waves to pass smoothly between the probe and the skin, enhancing signal quality. The Doppler probe is then angled gently toward the artery. Commonly, the dorsalis pedis on the top of the foot or the posterior tibial artery behind the ankle bone. The device converts the frequency changes from red blood cell movement into audible sounds. Arterial blood flow is recognized by a rhythmic pulsatile whooshing sound, while venous blood flow gives a steady, continuous tone, much like a soft blowing wind. This technique becomes especially vital in clients with peripheral arterial disease, where pulse palpation is often challenging due to reduced blood flow. Using the Doppler, the nurse can assess the presence and quality of arterial flow, identify occlusions, and monitor circulation following vascular procedures or the application of tight dressings and casts. Looking more closely at the distractors, option A, placing the probe beside the ankle, is incorrect because it focuses on location rather than the proper use of technique. Merely positioning the probe does not ensure accurate transmission. Option C, recording capillary refill time, assesses microcirculation at the capillary level and does not involve Doppler use. It evaluates perfusion but not arterial patency. Option D, measuring skin temperature, can provide indirect evidence of perfusion, for example, cool skin suggesting poor flow, but is unrelated to Doppler operation and accuracy. Transitioning to a deeper clinical reflection, here is the Stan Coast clinical insight. No gel, no flow because air blocks ultrasound waves. Always apply gel before positioning the probe and slowly adjust the angle until that distinct whooshing sound confirms arterial life. And continuing into the key learning takeaway, here is the Stan Coast high-yield NCLEX Pearl. Doppler detects what fingers cannot. Arterial flow creates a pulsating whoosh, while venous flow produces a gentle hum. Always remember, gel bridges the sound, not just the skin. Let us move forward into an interesting vascular concept involving Raynaud's disease. A 36-year-old client with a 7-year history of Raynaud's disease arrives at a community blood drive intending to donate blood. The question is, considering the client's diagnosis, in which part of the body would the nurse expect the client's symptoms to be primarily localized? Here are the options to consider: legs, hands, chest, or neck. The correct answer is hands. When exploring this scenario, it is essential to understand the underlying mechanism of Raynaud's disease. This condition is characterized by episodic vasospasm of small arteries and arterioles, predominantly in the distal extremities, most notably the fingers and hands. These vasospastic events are triggered by exposure to cold, emotional stress, or vibration, leading to temporary ischemia. The exaggerated vascular reactivity stems from increased alpha-adrenergic response and endothelial dysfunction, both of which impair normal vasodilation and promote constriction of the blood vessels. Clinically, Raynaud's follows a distinct color change pattern that helps nurses recognize it immediately. Pallor or whiteness due to lack of blood flow, cyanosis or bluish discoloration from deoxygenated blood, and finally, rubor or redness as rewarming causes reactive hyperemia. Clients often describe sensations of coldness, numbness, tingling, or even throbbing pain during these episodes. Repeated ischemic events may lead to long-term complications such as brittle nails, shiny skin, or ulcerations at the fingertips in severe cases. Comparatively, the legs, chest, and neck are rarely affected. The hands are far more susceptible because they are frequently exposed to cold temperatures and contain dense networks of arteriovenous anastomoses that respond strongly to sympathetic stimulation. From a nursing care standpoint, education and prevention are vital. Nurses should teach clients to avoid cold environments, wear insulated gloves when handling cold objects, and abstain from smoking, as nicotine intensifies vasoconstriction by increasing catecholamine release. Emotional regulation and avoidance of stress-induced triggers are equally important, as is avoiding vasoconstrictive medications like beta blockers and decongestants. Transitioning into our Stan Coast clinical insight, think cold fingers, color changes, and circulation crises. Raynaud's always starts at the tips, protect the hands, prevent the spasm, and promote warmth. Moving on to the Stan Coast high-yield NCLEX Pearl. In Raynaud's, the hands tell the story: white, blue, then red. The legs stay quiet, but the fingers cry for warmth. Remember, stress and cold are the real culprits. Moving into this engaging case, picture a 35-year-old client recently diagnosed with Raynaud's disease who is receiving counseling about how to prevent painful vasospastic attacks. During the discussion, the client mentions that the discomfort often begins suddenly after certain environmental exposures. The question then arises: which environmental factors should the nurse identify as most likely to trigger these symptoms? The available options include exposure to heat, exposure to cold, exposure to sun, and exposure to wind. The correct answer is exposure to cold. In-depth understanding of this condition reveals that Raynaud's disease is a functional peripheral vascular disorder, marked by episodic vasospasm of small arteries and arterioles, primarily in the fingers and sometimes in the toes. The underlying problem involves an exaggerated alpha-adrenergic response and endothelial dysfunction, both of which lead to excessive vasoconstriction when the client is exposed to cold temperatures or emotional stress. When cold triggers the sympathetic nervous system, the digital arteries constrict intensely, restricting blood flow and oxygen delivery. This physiological change results in the classic triphasic color pattern: white or pallor from ischemia, blue or cyanosis from deoxygenation, and red or rubor when blood flow returns during rewarming due to reactive hyperemia. During these attacks, clients typically describe sensations of numbness, tingling, or throbbing pain, especially in the fingers or toes. Because cold exposure directly stimulates sympathetic vasoconstriction, it remains the most frequent trigger. Therefore, nurses should educate clients to wear insulated gloves, avoid sudden temperature changes, and maintain overall warmth to minimize these painful episodes. Emotional stress, nicotine use, and caffeine intake can further worsen the vasospasm by increasing sympathetic stimulation, making it crucial to manage these aggravating factors as well. Analyzing the incorrect options provides additional insight. Exposure to heat actually promotes vasodilation, which helps relieve symptoms rather than trigger them. Similarly, sunlight exposure increases blood flow through local vasodilation, which may worsen conditions like lupus, but not Raynaud's disease. Lastly, while exposure to wind can feel uncomfortable, it does not directly cause vasospasm unless it is a cold wind, meaning the true trigger is temperature, not air movement. Transitioning into the Stan Coast clinical insight, always remember this key principle. Think chill equals constrict. When the temperature drops, the vessels clamp, blood flow halts, and fingers turn white, blue, then red. Warmth and calm are the nurse's best tools to break the spasm cycle. Moving forward to the Stan Coast high-yield NCLEX Pearl, keep this golden takeaway in mind. In Raynaud's disease, cold is the culprit. Stress and smoking are accomplices. Protect the hands, avoid temperature extremes, and teach clients to recognize early color changes to prevent ischemic injury. Shifting our attention to a real-world clinical teaching moment, imagine a nurse preparing a discharge plan for a client who has just been diagnosed with Raynaud's disease. The focus of this teaching is to help the client understand how lifestyle changes can prevent painful vasospastic episodes. The question asks which factor the nurse should instruct the client to strictly avoid to minimize the frequency and severity of symptoms. The available options include A. Wearing gloves during cold weather, B. Emotional stress, C. Drinking alcoholic beverages, and D. Bathing with perfumed soap. The correct answer is B. Emotional stress. In Raynaud's disease, also known as Raynaud's phenomenon, the problem lies in the exaggerated vasoconstrictive response of small arteries and arterioles, particularly in the fingers and toes. Emotional stress, whether from anxiety, fear, or anger, triggers the sympathetic nervous system, leading to the release of catecholamines, such as epinephrine and norepinephrine. These chemicals act on alpha-adrenergic receptors in vascular smooth muscle, causing intense arteriolar constriction that drastically reduces blood flow to the digits. This results in the classic triphasic color change. First white, pallor from ischemia, then blue, cyanosis from deoxygenation, and finally red, rubor, upon rewarming as circulation returns. During these episodes, clients commonly report numbness, tingling, throbbing pain, and color changes in their fingers or toes. Because both cold exposure and emotional stress can precipitate such attacks, teaching stress reduction techniques, such as deep breathing, guided imagery, yoga, or relaxation therapy, becomes a cornerstone of nursing management. Looking closer at the alternatives, option A, wearing gloves during cold weather, is actually beneficial and recommended because insulated gloves help maintain warmth, prevent vasospasm, and improve circulation. Option C, drinking alcoholic beverages, may cause rebound vasoconstriction after initial vasodilation if consumed in excess, but moderate consumption is not a common trigger for Raynaud's attacks. Still, alcohol intake should be minimized for vascular health. Option D, bathing with perfumed soap, may lead to skin irritation or dryness, but does not provoke vasospasm. Clients are instead advised to use gentle cleansers and maintain good skin care to prevent ischemic injury. Transitioning to the expert insight, it is worth remembering the Stan Coast clinical insight. Stress squeezes vessels just like cold constricts fingers. Both turn comfort into color change. Calm hands mean calm circulation. And reflecting further through the Stan Coast high-yield NCLEX pearl, in Raynaud's disease, emotional control is as vital as temperature control. Teach clients to keep both their hands and hearts calm, because sympathetic surges cause the spasm, not just the cold. Moving forward with another insightful clinical scenario, imagine a 32-year-old client who has been diagnosed with thromboangiitis obliterans, commonly known as Buerger's disease. The question focuses on identifying which early symptom this client is most likely to report. The options provided are A. A heavy feeling in the lower extremities, B. Frequent problems with ingrown toenails, C. Leg pain accompanying walking or exercise, and D. Swollen feet at the end of the day. The correct answer is C. Leg pain accompanying walking or exercise. Thromboangiitis obliterans is a progressive, non-atherosclerotic inflammatory disorder that affects small and medium-sized arteries and veins, especially in the distal limbs. The earliest and most characteristic symptom is intermittent claudication, which presents as cramping, aching, or burning pain in the calves, feet, or even hands during activity that resolves with rest. This pain arises because inflamed and narrowed vessels cannot meet the increased oxygen demand of muscles during exercise, leading to transient ischemia. Over time, as inflammation and thrombus formation worsen, pain may persist even at rest, particularly at night when circulation naturally slows. The root cause of this vascular damage lies primarily in tobacco use. Chemicals in cigarettes, particularly nicotine and carbon monoxide, cause direct endothelial injury, trigger inflammation, and promote vasoconstriction. The result is panarteritis, inflammation that involves all layers of the arterial wall, culminating in vessel occlusion, ischemia, and tissue hypoxia. Therefore, the most critical nursing intervention is absolute smoking cessation, as continuing to smoke will inevitably lead to disease progression and possibly limb amputation. When analyzing the incorrect options, option A, which describes a heavy feeling in the legs, is more typical of chronic venous insufficiency or varicose veins, conditions caused by venous pooling rather than arterial ischemia. Option B, frequent ingrown toenails, is unrelated to vascular health and is instead linked to improper nail trimming or tight footwear. Option D, swollen feet at the end of the day, also corresponds to venous stasis rather than arterial disease. In Buerger's disease, edema is not a primary early feature since the underlying issue is inadequate arterial perfusion, not venous congestion. Transitioning into clinical mastery with Stan Coast. Clinical insight. Intermittent claudication is the earliest cry for oxygen from starved muscles. Pain with activity, relief with rest. It is the body's signal that blood cannot keep up with demand. Leading into the Stan Coast high-yield NCLEX pearl. Buerger's disease belongs to smokers. The first sign is cramping calf pain on exertion, not swelling or heaviness. The most effective nursing teaching is absolute smoking cessation. It is the only proven way to halt the disease before ischemic ulcers and gangrene appear. Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just gliding ahead into another critical vascular nursing concept, let us focus on a clinical assessment that often reveals a key diagnostic clue. A nurse is palpating the peripheral pulses in the lower extremities of a client diagnosed with thromboangiitis obliterans, also known as Buerger's disease. The question asks which pulse characteristic the nurse should expect to document. The available options are A. Strong, B. Normal, C. Full, and D. Weak. The correct answer is option D, weak, thromboangiitis. Obliterans is a chronic, inflammatory, non-atherosclerotic occlusive disease that primarily involves the small and medium-sized arteries and veins of the distal extremities, especially the hands and feet. This disease causes segmental inflammation of the vessel walls, followed by thrombus formation and fibrosis, which progressively narrow or even completely block the vascular lumen. Because of this severe obstruction, the blood flow to distal tissues becomes markedly reduced, resulting in tissue hypoxia, ischemia, and eventually necrosis if left untreated. Consequently, peripheral pulses located distal to the occluded segment, such as the dorsalis pedis or posterior tibial pulses, become weak, diminished, or even absent when palpated. Early in the disease, these pulses may still be present but are faint and easily obliterated with light pressure. As the disease advances, they may disappear completely, signaling severe ischemia. The affected limb may appear cool, pale, or cyanotic, with a delayed capillary refill. Patients often complain of intermittent claudication, characterized by cramping pain in the legs or feet during activity that subsides with rest, reflecting oxygen supply-demand mismatch during exertion. On the other hand, a normal or strong pulse indicates adequate arterial blood flow, which contradicts the fundamental pathophysiology of Buerger's disease. Similarly, full pulses are typically found in hyperdynamic states or conditions associated with increased blood volume or vasodilation, not in occlusive arterial disorders. Hence, recognizing weak or absent pulses is vital to understanding the severity of ischemia. From a nursing standpoint, meticulous pulse assessment helps track disease progression and evaluate treatment effectiveness. The cornerstone of management is complete smoking cessation, as nicotine and other chemicals in tobacco perpetuate vasoconstriction, endothelial injury, and inflammation. Nurses play a crucial role in client education, encouraging avoidance of cold exposure, maintaining meticulous foot hygiene, and promptly reporting any pain, color change, or ulceration to prevent gangrene and potential limb loss. Transitioning into a clinical takeaway with Stan Coast. Insight. In Buerger's disease, a weak or absent pulse is not merely a physical finding, it serves as a critical alarm that tissues are being deprived of oxygen. Early identification through vigilant nursing assessment can prevent irreversible ischemic injury. And moving toward a Stan Coast high-yield NCLEX Pearl. Keep this golden rule in mind. A weak or absent distal pulse in a young smoker with leg pain points toward Buerger's disease, not atherosclerosis. The absolute nursing priority is complete smoking cessation. No reduction, no exceptions. Hold on a second before we dive into the next NCLEX topic. I need to share something urgent with you. If you are serious about passing the NCLEX on your very next attempt, you cannot afford to miss the ultimate NCLEX crash course. More than 100,000 students have already cleared their exam with it, and you can too. Why is this course different? Because it gives you everything in one place. Live interactive classes, recorded lectures you can rewatch anytime, 5,000 practice-style questions, 30 practice tests, ebooks and PDF revision notes, a student planner, and detailed NGN question explanations. This is your shortcut to success. Don't wait. Scan the QR code or click the link in the description now. You will instantly unlock free study content including NCLEX quizzes, PDF notes, and practice tests, plus access to our Telegram and WhatsApp groups with even more support. Moving forward into this insightful clinical discussion, let us explore how a nurse evaluates a client diagnosed with thromboangiitis obliterans, also known as Buerger's disease, who has been instructed to perform Buerger-Allen exercises to promote arterial circulation in the lower extremities. The nurse determines that the client demonstrates the correct understanding of the exercise sequence when the client lies flat with the legs elevated for several minutes and then performs which action? Here are the available options. A. Sits on the edge of the bed with legs in a dependent position. B. Stands and bends forward to touch the toes. C. Jogs in place at the bedside to increase circulation. And D. Simulates stair climbing while sitting up in bed. The correct answer is option A. Sits on the edge of the bed with legs in a dependent position. Buerger-Allen exercises are a well-structured therapeutic regimen used to enhance collateral circulation and improve tissue perfusion in clients with peripheral arterial disease, particularly those suffering from thromboangiitis obliterans. These exercises strategically employ postural changes to alternately drain venous blood and stimulate arterial inflow. The correct performance begins with the client lying flat and elevating the legs above heart level for about 2 to 3 minutes, which helps drain venous and deoxygenated blood from the extremities. Next, the client sits on the edge of the bed or chair with legs in a dependent position for another 2 to 3 minutes until a hyperemic flush appears, indicating improved arterial blood flow. Finally, the client lies flat once more and performs active movements such as dorsiflexion, plantar flexion, and foot rotation to maintain muscle pump activity and support venous return. These exercises should be performed 3 to 4 times daily to encourage the development of collateral vessels and adaptive perfusion in ischemic tissues. This conservative measure is particularly important for patients who cannot undergo surgical revascularization. The nurse should also teach that any exercise involving weight-bearing, toe-touching, or jogging is contraindicated, as such activities can aggravate ischemic pain and worsen symptoms like intermittent claudication or rest pain. Considering the incorrect choices, option B, stands and bends forward to touch the toes, is not appropriate because this posture increases intra-abdominal and intrathoracic pressure, decreasing venous return and worsening ischemia. Option C, jogs in place at the bedside, is unsafe as it heightens oxygen demand in the lower extremities, potentially leading to pain and tissue damage due to limited oxygen delivery. Option D, simulate stair climbing while sitting up in bed, is also incorrect, because this movement lacks any arterial benefit and may cause unnecessary strain without improving circulation. Transitioning now to a valuable clinical insight, stand coast. Clinical insight. Buerger exercises use gravity, not exertion, to restore blood flow. Elevate, dangle, rest, and repeat, the rhythm that retrains the arteries. And shifting into a high-yield examination focus, stand coast high-yield NCLEX. Pearl. In thromboangiitis obliterans, true improvement comes from 2 pillars: total smoking cessation and disciplined Buerger exercises. Together, they preserve limbs by maximizing every remaining vessel's potential. Diving into this important cardiovascular nursing concept, let us discuss a discharge teaching scenario involving a client newly diagnosed with Buerger's disease, also known as thromboangiitis obliterans. The nurse must decide which instruction to emphasize as the most critical to prevent further progression of the disease. Here are the available options. Option A advises avoiding heavy lifting or strenuous physical activity. Option B recommends completely abstaining from all forms of tobacco use. Option C suggests avoiding airplane travel for long distances. And Option D proposes limiting sexual activity until circulation improves. The correct answer is Option B, completely abstain from all forms of tobacco use. Buerger's disease, or thromboangiitis obliterans, is a chronic, non-atherosclerotic inflammatory disorder that affects small and medium-sized arteries and veins, primarily in the extremities. The key pathological feature is segmental inflammation and thrombotic occlusion triggered almost exclusively by nicotine exposure. Tobacco toxins cause endothelial injury, resulting in vasospasm, ischemia, and tissue necrosis. Because nicotine is the primary etiologic agent, absolute tobacco cessation remains the single most effective intervention to halt disease progression. Even minor nicotine exposure from smoking, chewing tobacco, or nicotine replacement therapies can rekindle vascular inflammation and worsen ischemic changes, increasing the risk of ulceration and gangrene. Therefore, nurses must educate clients that the only proven way to prevent amputation and improve limb viability is the complete and permanent elimination of all nicotine sources. Let us now clarify why the other options are not correct. Option A, avoiding heavy lifting or strenuous activity, is inaccurate because while excessive exertion may temporarily worsen ischemic pain, moderate activity such as walking can enhance collateral circulation. The underlying issue in Buerger's disease is vascular inflammation, not muscular strain. Moving to option C, avoiding airplane travel for long distances is unnecessary because air travel does not directly affect arterial inflammation. The concern during long flights is venous stasis and dehydration, which can be prevented by ambulation, hydration, and compression stockings. The pathology in Buerger's disease is arterial, not venous, making this restriction irrelevant. Lastly, option D, limiting sexual activity until circulation improves, is incorrect because sexual activity is not contraindicated unless the client experiences pain, ulceration, or severe ischemia. It has no direct impact on arterial perfusion. Transitioning to the key nursing perspective, this condition underscores the importance of behavioral modification over pharmacologic management. Nurses play a vital role in providing smoking cessation counseling, connecting clients to behavioral therapy programs, and reinforcing that relapse can rapidly accelerate disease progression. Transitioning now to a valuable clinical insight, Stancoast Clinical Insight. Before concluding, it is vital to remember this practical wisdom. Nicotine is the true trigger. One puff, one pinch, one patch can restart the vascular fire. Only complete cessation cools the inflammation and saves the limb. And shifting into a high-yield examination focus, Stancoast High-Yield NCLEX Pearl. Finally, keep this golden pearl in mind. In Buerger's disease, the only proven therapy is total tobacco cessation. All other interventions are supportive. Discipline, not medication, determines limb survival. Moving into this detailed clinical reasoning scenario, imagine a nurse conducting a routine assessment in a long-term care facility when an abdominal X-ray unexpectedly reveals that an elderly resident has developed an abdominal aortic aneurysm, commonly referred to as AAA. The nurse now reviews the client's medical history to pinpoint which predisposing factors may have contributed most significantly to this vascular condition. The question asks, which findings in the client's history represent the most critical risk factors for developing an abdominal aortic aneurysm? Here are the options to consider. Option A states that the client has type 1 diabetes mellitus. Option B indicates the client has chronic hypertension. Option C mentions a sedentary lifestyle. Option D notes that the client takes digoxin, also known by its brand name Lanoxin. Option E highlights that the client is 80 years old, and Option F reveals that the client smokes 2 packs of cigarettes per day. The correct answers are options B, E, and F: chronic hypertension, advanced age, and heavy smoking, as these represent the most influential risk factors in the development of an abdominal aortic aneurysm. To understand why these are correct, let us explore the advanced clinical explanation. An abdominal aortic aneurysm is a localized dilation of the abdominal aorta that results from progressive weakening of the arterial wall. It most often occurs below the renal arteries and above the iliac bifurcation. The underlying pathophysiology centers on the loss of elastin and collagen fibers within the vessel's media and adventitia layers, which leads to decreased wall strength. As wall tension increases in accordance with Laplace's law, the likelihood of rupture grows exponentially with the diameter of the aneurysm. Chronic hypertension, represented by option B, is one of the most potent risk factors. Sustained high blood pressure exerts continuous stress on the arterial wall, promoting endothelial injury, accelerating atherosclerotic plaque formation, and weakening the vessel structure over time. This makes the aorta susceptible to dilation and rupture. Advanced age, indicated in option E, also plays a major role. As individuals grow older, especially beyond 65 years, there is a natural decline in vascular elasticity due to degeneration of elastin and collagen, decreased compliance, and cumulative exposure to vascular damage. At 80 years old, this client's risk is markedly elevated. Lastly, heavy cigarette smoking, represented by option F, is the most significant modifiable factor. Nicotine and carbon monoxide induce oxidative stress, promote smooth muscle apoptosis, and impair the integrity of the arterial wall. Even after cessation, vascular damage persists for years, keeping the risk of aneurysm high. On the other hand, certain options do not contribute significantly to aneurysm development. Type 1 diabetes mellitus, option A, interestingly has a slightly protective effect against aneurysm formation due to collagen cross-linking that increases arterial stiffness, reducing the likelihood of dilation. A sedentary lifestyle. Option C, though detrimental to general cardiovascular health, does not directly cause aneurysm formation, but may indirectly worsen atherosclerotic risk. Lastly, the use of digoxin, option D, affects heart contractility, but bears no connection to aneurysmal disease and is therefore clinically irrelevant in this context. Transitioning now to the deeper insight, here comes the Stancoast Clinical Pearl, which emphasizes an aneurysm does not develop overnight. It is the silent consequence of years of vascular injury. The combination of age, pressure, and poison, meaning smoking, forms the lethal triad that silently stretches the aorta until it gives way. Following that, the Stand-Coast High-Yield NCLEX-style reinforces the memory cue with, when assessing risk for abdominal aortic aneurysm, remember the rule of three: older age, uncontrolled hypertension, and chronic smoking. These three factors alone can predict over 80% of aneurysm cases in older adults. Shifting to a clinical scenario that highlights critical assessment skills, picture a 72-year-old male client with a long-standing history of hypertension and heavy smoking who presents with a dull, constant abdominal pain radiating to his lower back. During a comprehensive abdominal examination, the nurse performs gentle palpation while observing for vascular changes. The question asks, which assessment finding would be most characteristic of an abdominal aortic aneurysm, also known as AAA? The options are as follows. Option A, bilateral pedal edema. Option B, hypoactive bowel sounds. Option C, multiple abdominal petechiae. And option D, a palpable pulsating abdominal mass. The correct answer is option D, a palpable pulsating abdominal mass. To understand this fully, when assessing a client suspected of having an abdominal aortic aneurysm, the most critical and characteristic finding is a palpable pulsating mass located in the mid or upper abdomen, typically slightly left of the midline. This pulsation occurs due to turbulent blood flow through a weakened and dilated section of the aortic wall. The aneurysm often develops below the renal arteries, infrarenal region, where chronic hypertension, cigarette-induced oxidative damage, and atherosclerosis progressively weaken vessel integrity. The pulsation is expansal, meaning it moves outward in all directions. Unlike transmitted pulses seen in normal arteries, it is crucial for nurses to avoid deep palpation because excessive pressure could precipitate aneurysm rupture. Instead, the nurse should gently observe and auscultate for a bruit, which reflects turbulent blood flow within the aneurysmal segment. If rupture occurs, the client may suddenly develop severe abdominal or back pain, hypotension, tachycardia, and signs of hypovolemic shock, all indicators of a life-threatening emergency demanding immediate medical attention. Looking at the incorrect alternatives, option A, bilateral pedal edema, does not characterize an abdominal aortic aneurysm. Edema typically occurs in conditions involving venous congestion, right-sided heart failure, or renal dysfunction, whereas AAA primarily affects arterial flow. In such cases, lower extremities are more likely to display coolness, pallor, diminished pulses, and delayed capillary refill rather than swelling. Moving to option B, hypoactive bowel sounds are generally unrelated to AAA because the aneurysm involves the arterial system rather than the gastrointestinal tract. Bowel sounds would only diminish if secondary hypoperfusion or internal bleeding occurred after rupture. Lastly, option C, multiple abdominal petechiae, are pinpoint hemorrhagic spots associated with platelet disorders, sepsis, or liver dysfunction, and not with aneurysmal pathology. AAA affects large vessels, not the capillaries responsible for petechiae formation. Transitioning now to a deeper insight, Stand-Coast. Clinical insight reminds us that an abdominal aortic aneurysm is like a silent ticking bomb. The larger it grows, the greater the tension on its wall, and the higher the risk of rupture. Therefore, gentle nursing assessment, vigilant monitoring, and early detection are truly life-saving. Moving forward with a Stand-Coast high-yield NCLEX-style, always remember, never palpate a suspected abdominal aneurysm. Instead, assess cautiously by observation and auscultation. The key differentiating sign is that an aneurysm pulsates rather than peristalsis, and this single observation could save a life. Moving into a critical concept that often confuses students, let us explore the client's understanding of an abdominal aortic aneurysm. During a teaching session about this life-threatening vascular condition, the nurse assesses comprehension and asks which statement by the client reflects an accurate understanding. The available options are option A, an aneurysm is a weakened valve in the abdominal aorta. Option B, an aneurysm is a stationary blood clot in the abdominal vein. Option C, an aneurysm is a fatty deposit in the aorta wall. And option D, an aneurysm is an outpouching in the wall of the abdominal aorta. The correct answer is option D. An aneurysm is an outpouching in the wall of the abdominal aorta. When we break this down, an aneurysm represents a balloon-like dilation or localized outpouching of an artery due to weakening of its muscular middle layer, known as the media. This weakening disrupts the vessel's ability to withstand normal pressure, causing progressive expansion. The abdominal aorta, especially its infrarenal portion below the renal arteries, is the most frequent site because it endures the greatest mechanical stress from circulating blood. Chronic hypertension, atherosclerosis, and cigarette smoking are leading culprits, as they cause gradual degradation of the vessel wall's elasticity. Over time, the aneurysm enlarges and risks rupture, leading to catastrophic internal hemorrhage and circulatory collapse. Therefore, when the client correctly identifies an aneurysm as an outpouching in the aortic wall, it demonstrates clear understanding of both anatomy and pathophysiology. Looking at the incorrect options, let us clarify why each one does not apply. Option A, an aneurysm is a weakened valve in the abdominal aorta, is inaccurate because valves exist only in veins, not arteries. Valves prevent backward blood flow in veins, whereas aneurysms form in arteries due to wall weakness. Weak venous valves instead cause varicose veins, not aneurysms. Option B, an aneurysm is a stationary blood clot in the abdominal vein, is also incorrect because a stationary clot is known as a thrombus, which typically occurs in veins as deep vein thrombosis. Thrombosis involves coagulation of blood, not vessel wall dilation. Meanwhile, option C, an aneurysm is a fatty deposit in the aorta wall, misrepresents the concept. Fatty deposits refer to atherosclerosis, which causes narrowing of arteries rather than dilation. However, chronic atherosclerosis may contribute to aneurysm formation by weakening the arterial wall over time. Transitioning to an essential clinical reminder, here comes the Stan Coast clinical insight. Think of an aneurysm like a balloon under constant pressure. The more it stretches, the thinner and weaker its wall becomes, and once it bursts, fatal bleeding can occur within moments. Following that, let us emphasize the Stan Coast high-yield NCLEX pearl. Never palpate a suspected abdominal aortic aneurysm, as it can precipitate rupture. Instead, assess gently by auscultating for a bruit over the abdomen. Report any sudden severe abdominal or back pain, low blood pressure, or signs of shock immediately. Finally, remember that screening is vital for men over 65 years old with a history of smoking or hypertension, as early detection can truly save lives. Transitioning into an important vascular emergency scenario. Imagine a client residing in a long-term care facility who has a known abdominal aortic aneurysm but refuses surgical repair, opting instead for conservative management. In such a situation, the nurse's primary responsibility is vigilant monitoring for any new or worsening symptoms that might signal aneurysm enlargement or dissection. The question asks which newly reported symptom should immediately alert the nurse to possible aneurysm progression. The options are Option A, hematuria, Option B, indigestion, Option C, rectal bleeding, and Option D, persistent lower back or flank pain. The correct answer is Option D, persistent lower back or flank pain. When an abdominal aortic aneurysm enlarges or begins to dissect, the earliest and most characteristic manifestation is deep, unrelenting lower back or flank pain. This pain occurs because the expanding aneurysm exerts pressure on adjacent vertebral bodies, nerves, and surrounding tissues. Unlike ordinary back pain, it is described as gnawing, steady, and unrelieved by rest, position change, or analgesics. As the dissection progresses, blood seeps between the layers of the aortic wall, creating a false lumen that stretches and weakens the vessel even further, an ominous sign that rupture may be imminent. Moving into the pathophysiologic sequence, if rupture occurs, the client can suddenly develop signs of massive internal bleeding, such as hypotension, tachycardia, pallor, diaphoresis, and eventually hemorrhagic shock. Sometimes, the bleeding initially collects behind the peritoneum, leading to retroperitoneal tamponade, but this only delays the inevitable. Therefore, any new onset of persistent back pain in a client with an existing abdominal aortic aneurysm must be treated as a medical emergency. The nurse's immediate priority is to notify the healthcare provider and prepare for imaging evaluations such as ultrasound or CT angiography to confirm dissection or leakage. Now, let us evaluate the incorrect options. Option A, hematuria, is not a common or expected symptom of aneurysm enlargement. It generally points toward kidney trauma, infection, or glomerular disease rather than vascular pathology. Though an aneurysm might compress nearby renal arteries, Hematuria would be a late and atypical manifestation. Option B, indigestion, may seem like a vague discomfort, but is more consistent with gastrointestinal issues such as reflux or peptic ulcer disease. It lacks the deep, constant nature of aneurysmal pain and is not a reliable indicator of dissection. Option C, rectal bleeding, originates from the lower gastrointestinal tract and is unrelated to aortic disease. Only in the rare instance of an aortoenteric fistula, a direct abnormal connection between the aorta and intestine, would bleeding occur, and even then, it would present as a catastrophic, life-threatening event rather than an early warning sign. Finally, reflecting on key clinical wisdom, the Stan Coast clinical insight reminds us that persistent lower back pain in a client with an abdominal aortic aneurysm is a red flag symptom, indicating that the aortic wall may be stretching to its limit. Once rupture occurs, survival chances drop dramatically. Mortality exceeds 80% even with emergency surgery. Complementing this, the Stan Coast high-yield NCLEX Pearl reinforces that nurses should always assess for sudden, severe, and constant abdominal or lower back pain in clients with known AAAs, never palpate a pulsating abdominal mass to avoid precipitating rupture, monitor for a pulsatile abdominal mass or a BRU, and promptly act if hypotension or restlessness develops. The nurse's decisive intervention in recognizing these signs can truly make the difference between life and death. Moving deeper into another ethical and clinical decision-making scenario, picture this: a 76-year-old client with a previously diagnosed abdominal aortic aneurysm has made their wishes clear through a signed advance directive that explicitly states no heroic measures. And the physician has documented this as a do not resuscitate or allow natural death order. During a home care visit, the client suddenly collapses, becomes pulseless, and remains unresponsive following what appears to be a rupture of the aneurysm. The question asks, what should the nurse do at this exact moment? The available options are as follows. Option A suggests transferring the client immediately to the hospital for surgical intervention. Option B advises calling emergency medical services for advanced resuscitation. Option C recommends notifying the attending physician of the client's change in condition. And Option D proposes contacting the client's next of kin to inform them of the event. The correct answer here is Option C. Notify the attending physician of the client's change in condition. The reasoning behind this decision is deeply rooted in both legal and ethical nursing practice. When a client with a documented DNR or AND order becomes unresponsive due to a catastrophic event, such as a ruptured abdominal aortic aneurysm, the nurse's foremost duty is to honor the client's previously stated wishes. A DNR order means that no cardiopulmonary resuscitation, defibrillation, intubation, or any other life-prolonging interventions are to be performed. Therefore, Option C is correct because notifying the physician ensures professional continuity of care, allows for accurate documentation, and enables further coordination of appropriate actions such as hospice involvement, death verification, or family notification. This approach respects the client's right to die with dignity, free from unwanted or invasive procedures. From an ethical standpoint, three major principles come into play: autonomy, beneficence, and non-maleficence. Autonomy demands that nurses respect a client's right to make informed choices regarding their own care, even if that choice means refusing life-sustaining treatment. Beneficence requires the nurse to act in the client's best interest, which in this case means ensuring a peaceful and dignified natural death rather than aggressive intervention. Non-maleficence reminds the nurse to avoid harm. Performing CPR or initiating resuscitation on a client with a DNR would not only be futile, but also ethically and legally wrong. Documentation plays a crucial role at this point. The nurse should promptly and clearly record the client's observed condition, time of collapse, absence of pulse or respirations, and all communications made, especially the notification to the physician and any directions subsequently received. Once the physician has been informed and verified the situation, the next of kin can be contacted, usually under the physician's instruction or according to facility policy, to ensure emotional support and appropriate post-death procedures are followed. Now, let us understand why the other options are incorrect. Option A, transferring the client to the hospital, directly violates the advance directive and DNR order because it constitutes a heroic measure aimed at life prolongation. Doing so would disregard the client's autonomy and expressed preferences. Option B, calling emergency medical services, is also incorrect, as their protocols include initiating CPR and other advanced life-saving interventions, which would conflict with the DNR order. Option D, contacting the next of kin, though necessary eventually, is not the immediate nursing priority. The physician must first be notified, as they are responsible for confirming the event and directing next steps. Before moving on, here is a valuable insight. Stand coast. Clinical insight. Respecting a client's advance directive is not the absence of care. It represents the highest form of ethical nursing, where dignity, autonomy, and compassion are upheld at the end of life. And to strengthen your exam readiness, here comes your Stand Coast High-Yield NCLEX Pearl. Always verify the presence and validity of a DNR or advance directive upon admission and during every transition of care. In the event of deterioration, the nurse must withhold resuscitation and notify the physician, not emergency services. Document clearly. Record the client's condition, withheld interventions, notifications, and the emotional support provided to the family. Remember, NCLEX questions about DNR or end-of-life care test your understanding of autonomy, ethics, and prioritization. Always choose the response that preserves dignity and aligns with the client's documented wishes.